Hi everyone, this is Zach Ford with Age United's Sector Transformation Program. Thank you for joining us today for the first webinar in our Monetization series. This webinar will focus on the HCBO payer relationship. The webinar will last approximately 1 hour and will include time for question and answer at the end. As a reminder, this webinar is being recorded and participants are in listen-only mode. You can listen by calling 1-866-740-1260 and use access code 876-2819, or enabling the audio in ReadyTalk to listen over your computer speakers. Please use the chat function to ask us a question. At Age United, our mission is to end the AIDS epidemic in the United States through strategic grant-making, capacity building, policy, technical assistance, and formative research. We are a national nonprofit organization with a singular mission and focus to end AIDS in the United States. We lead the charge for responsive and effective federal, state, and local policies that benefit people living with and at risk for HIV. We invest in innovative models to meet the needs of communities affected by HIV and AIDS. We have given more than $104 million in direct funding and leveraged $117 million to increase capacity of communities and organizations responding to HIV in the United States. We inform the field with best practices and lessons learned. We advance advocacy based on sound public policy, strategic grant-making to affected communities, targeted and tailored capacity building for organizations responding to the epidemic, and research and evaluation to inform the field. We work within a social justice framework that challenges the foundational issues of racism, sexism, homophobia and transphobia, socioeconomic inequality, gender discrimination, and stigma. We're excited to announce that this webinar series will include free one-on-one coaching with the Minges Group on a first-come, first-served basis. Any HCBO interested in individual coaching by the Minges Group regarding establishing and strengthening relationships with payer organizations should email myself and Paola Verona at st@ageunited.org. Today's webinar, we have the Minges Group, Joel Minges, the Chief Executive Officer, Purnima Singh, Vice President, Director, Government Contracting and Correctional Health Services, and Mohammed Hamdan, Research Consultant. And with that, I will turn it over to our presenters.
Hello, everyone. My name is Mo, and as Zach said, I'm the Research Consultant here at the Minges Group. We want to thank all of you for joining the first of our 6 webinar series. We are excited to help broaden educational access to contracting techniques between HCBOs and the payer community. At the end of this webinar, we hope you will all have a better baseline understanding of the payer environment. This session will also help teach you how to assess your organization's strengths and opportunities to strategically engage with the payer community. The topics we're going to cover today include opportunities to work with MCOs and payers to support their enrollees. And this involves identifying service gaps payers face that HCBOs are ideally positioned to fill, high-risk and at-risk populations and ways HCBOs currently serve or can adapt to serve these groups. And so HCBOs need to discern which payers cover large populations of people living with or at risk of HIV, as well as other at-risk populations. And lastly, we're going to review ways to assess your organization's strengths, weaknesses, opportunities, and threats. And this will help you and your organization best prepare business and contracting strategies. So I guess the first question we should be answering is, why is it so important for HCBOs to begin partnering with the payer community? The Affordable Care Act, or the ACA, has resulted in greater access to health coverage than ever before for people living with HIV. Coverage is provided through both the private markets as well as Medicaid expansion in the 32 states, including the District of Columbia, that have chosen to expand. Additionally, Medicare is playing a large role in covering persons living with HIV, and this significant role is driven by the fact that in some circumstances, persons living with HIV with a disability qualify for Medicaid as well as Medicare, and these are your dual eligibles. And with health coverage playing a large role for people living with HIV, and with grant funding diminishing, which we're currently seeing right now with the Ryan White Foundation, it's increasingly important for HCBOs to deliver their services through contracts with managed care organizations, or MCOs, and other health insurance entities. This creates an additional path for reimbursement of HCBOs' existing medical services and non-medical support services, as well as opportunities for HCBOs to develop and deliver new services that are of value to the payer community and to people living with HIV. And this gives your organizations a lot of room for innovative solution development. And so for those of you who decide to do individual coaching with us, this can be really fun and exciting, and we look forward to speaking more with you guys.
This is Joel. One minor clarification on the individual coaching is it won't truly be one-on-one. It'll be sort of our company with whoever is involved from your company, but there'll be a team of us trying to help however many of you are involved from any given organization, and we really welcome that and are excited that that's part of this project. But back to the slides, we work mostly as a consulting firm with payers directly, and we can certainly vouch that they're not fundamentally evil organizations or anything like that, but they can be good, bad, or ugly in any given behavior, just like human beings and so forth. But I think it's helpful in the CBO community to make sure you don't come in with sort of a bias against the payer community as fundamentally being barriers to paying for needed things and so forth. That's not necessarily the culture, and a lot of the payers we work with, the people and the organizations couldn't be more opposite that in their orientation. So that's not to say any given payer won't do a terrible thing at a given moment, but fundamentally these organizations are positive players in the health system. They're helping. We work in the coordinated care arena, and moving people out of a fee-for-service structure where everyone goes where they want and the providers just do what they want, and somebody else's money just pays for whatever happens to happen isn't actually a good thing. A lot of people view that to be good or great coverage, but that's very ineffective coverage. That non-system doesn't have quality rigor to it. You're just paying for whatever occurred. It doesn't have cost effectiveness to it, and all these things are having the care be as cost effective and taking care of someone as inexpensively as possible, but as well as possible, is a very important policy need and program need. And the payer community sometimes does that, well, and sometimes not. But I think a lot of us are involved in trying to advance the ball in that arena, and it's exciting, important work, and it's certainly far from an evil enterprise type situation. So just wanted to kind of throw that out there just culturally. There isn't any unholier than thou aspect to that industry, I don't think, from having been directly involved in it for 30 plus years. One thing that's becoming more and more important in the Medicaid arena, and this may spread more outwards, but the Medicaid population, as Mo said, has grown dramatically, and the persons living with HIV portion of the Medicaid population has grown dramatically through Medicaid expansion. So Medicaid's become has become more important in the coverage and care for the infected population, and that population is overwhelmingly enrolled in Medicaid health plans now. From the health plan side, they are largely, other than a handful of states, the health plans are being determined through a competitive procurement where the state's saying, I'm going to take the best 4 or the best 5, or in a given county, just the best 3, and people fight for that business. And those are the largest contracts state governments have. They're enormously competitive, so the health plan community is put into a lion's den regarding who will be one of the 4. And we happen to have a huge involvement in that procurement work, but from the CBO's point of view, there's a great opportunity through these procurements to create partnerships that might not otherwise occur, because the health plans need to get their nose above all their competitors in their bid, and having partnerships with your organizations can be a great way to scare up a few more much needed points in the procurement process. And your guys' acumen in getting at a high need population and at the social determinants of health are very important. In terms, and just to the extent it's helpful, just trying to convey how payers think from us having been largely inside that tent. I think there's a misperception that health plans don't want to serve costly people. They don't even want to enroll them. That has certainly been the case, in years past, with a lot of health insurance entities trying to get the healthiest population they can. But now the people who are paying the premiums have figured out how to risk adjust rates. So if somebody has healthier people, they get a smaller premium than if they have unhealthier people. And there's risk adjustment factors for HIV, for persons who have HIV and who have cancer and diabetes and everything else you can name. And so it's kind of become neutralized to a large degree. It's still imperfect, but there isn't anymore a scene where having healthier than average people is beneficial to a health plan. That might just corner the health plan into having much lower revenue. Most of the money in the healthcare system is associated with high need people. The 20 or less percent of the high need people account for 80-90% of the health spend in the country. So, and the HIV population is certainly in that high group. So health plans have actually flipped from wanting to not have this population in their midst to wanting to have them and wanting to manage them effectively and serve them. And we see a lot of HIV-only health plans around the country, the Medicare special needs plans, and in Florida and New York, there's Medicaid special needs plans that every single enrollee in the health plan has HIV. So, health plans are increasingly interested in serving this population, but they still need a lot of help, and the skill set that your organizations have can be tremendously valuable to them in partnership. And so, the whole 6-month series we're doing will delve into this in different branches of that tree. But I just wanted to, debunk if needed that the health plans don't want the HIV population, because to a large degree they absolutely do. One counter to that on the last bullet on this slide is on the pharmacy cost arena. In most aspects of healthcare for persons with diabetes and most chronic conditions you can name, drug and HIV obviously, prescription drug adherence is front row center to helping the people do well. And in HIV, this is obviously the regimens have turned this condition from a death sentence to a manageable chronic condition. And we've got lots of people living extraordinarily long, healthy lives who with infection now, entirely because of the drug regimen. That's wonderful. The price of these drugs is disgustingly high. I don't know how to put it otherwise, but the prices are what they are. So for a health plan in general, a health plan will want to get a pharmaceutical product introduced as soon as possible. But for the HIV population at a cost of $20,000 a year, if the person's very low level HIV, they may not financially, they're not so excited about making that investment. at the point where the person starts having some symptoms and so forth, that changes. All of those dynamics have been in the way. If you the drug pricing has put an awkward, barrier to introducing the medications as early as would be clinically ideal, I think. And there's been a push and pull. One thing that's working in everyone's favor on this, I guess, except the drug manufacturers have already gotten, more than enough revenue out of their products, is the patents are going to expire. And so these drug prices, 5 and 10 years from now, it's going to be an entirely different economic ballgame. Right now, the medications are over half of the cost of HIV care, and that's going to probably drop to less than 10%, and that's going to change the dynamics of how you guys can partner. But at this point, going out into the community and getting better adherence for someone who's not sick isn't likely to be financially welcomed by a health plan. That's going to change. In terms of opportunities to work, I'm on the next slide. I talked about the procurements a fair bit, but these are crazy important moments in the health plan. This determines whether they exist or not, whether they're one of the four, and it can be a very minor number of points on a 1,000-point scale, or as to whether who's second, third, fourth, fifth, sixth, and seventh. And the plans are fighting hard to be above the cut line rather than below it, and the stakes couldn't be higher for them. Their jobs and their existence in a state depend on making it above that line. That breeds partnerships with your type of entity. The community involvement slide, there's a lot of requirements in terms of contracting with the safety net providers that you guys are directly are the safety net providers or are particularly plugged in with the safety net providers and can help the plans in that regard. With regard to just the cost-benefit ratio, and a lot of our seminar series is going to delve into this more, but there are lots of ways that what you do where, for every dollar they spend on you will save them more than $1 on their health spend. And, one thing you'll be hearing from us is, zooming in and doing data analytics with the health plan at the outset to identify which persons with HIV in the health plan's enrollment base are going to be most conducive to achieving savings. The ones who have had, 3, 4, 6, 8 admissions in the past couple of years are people that are screaming out for help and for more intensive HIV-tailored care coordination, which you and potentially only you can give in the community. And what you do for those organizations will be phenomenally cost-effective for them versus what they need to pay you. So those are the kinds of partnerships that we'll be exploring and talking about as we go through the whole series. This slide deck is more introductory. There are service gaps in the payer community. Moving to the next slide, in terms of it's buzzwordy, but the social determinants. We've done a fair amount of HIV coordinated care work through the past years, and for me the past decades. One of the fascinating things for me is how rarely HIV infection is the #1 issue/problem in the person's life. And that was even the case when the disease was a death sentence. The Medicaid poverty population's lives are so broken and challenged in so many ways that even having HIV in the 1990s wasn't their #1 problem if they were telling you what they're trying to do to get through the day-to-day. Now with it being a chronic condition with the meds, it's even further down the line. But how we, the poverty population that we've been most involved with, you can't overstate the importance of nutrition and diet and and the stability of the household and just housing in general. Having housing and stable housing, safe housing, et cetera. There's so many elements to this that are not health care, but which you guys are profoundly involved in helping your clientele access that can, like I said on the last slide, be tremendously cost effective for the health plan in terms of what it saves them in medical costs versus what they spend for you to help the person tend to their housing, nutrition, et cetera needs. So there's a lot of exciting opportunities there for you guys, we think. Finding and retaining members. A lot of health plans, the insults of poverty do create a lot of transience and a lot of homelessness or and difficulty just contacting people. But you guys have feet in the street in a much stronger way, particularly with your clientele. So just finding and retaining and staying connected to the members so they can adhere to their meds, so they don't touch the health system in the hospital at a point of deep crisis and they get patched up for $27,000 every 4 months. The health plan does not want that, and you guys can help find that person and take care of that person for them. And like I was saying, the data analytics at the front end of your contract with them can discern who those people are, who you can most help. The HIV drug costs, the adherence rates aren't optimal, and like I said, the price of these drugs creates a barrier to the health plan's enthusiasm to up adherence for people that don't seem to be sick. But there's a tremendous, enthusiasm on the health plan's part to get adherence to happen for those who are sick and are going to be in the hospital next week without continuity, or at least, within the next 3 months. So with that, I'll turn it over to Purnima, and she'll go through the rest, and then we'll take questions.
Thanks, Joel. So this might really get to something we learned from our engagement with the 4 HIV CBOs earlier last year. And you guys all probably do this to a degree today. Your high-risk, at-risk populations, you're not necessarily just serving, or not necessarily just have the capabilities only to serve just those living with HIV or at risk for contracting HIV, but you're actually, and you might not realize that you're managing a high-risk population, and you have the ability and capabilities most oftentimes to serve other individuals who fit that high-risk bucket. We've listed these last 3 bullets that really get to that. So persons with multiple chronic diseases, persons with comorbid behavioral and physical health conditions, and individuals transitioning back to the community from an incarceration. And just bringing in elements from items that Mo and Joel both discussed. When you're managing this population, when you're taking care of them, you're not just focusing on one particular area on their clinical needs. You're really thinking about their social needs as well, and that's super important with this high-risk, at-risk population. And that's where the managed care organizations, the payers, have difficulty. And so for you to be able to prove that and to come in and take on this population and demonstrate your ability to really gain a hold of this high-risk, high-need population and demonstrate that you're able to engage with this population is key, especially to payers. All right, so next slide. So this slide, again, bringing it full circle. So we're talking about the different payers here. And Medicaid, as Joel mentioned, Medicaid expansion does increase the volume of the population living with HIV, but it has a high proportion of high need members as well. And so does every other population. You have the individuals living with HIV in all 3 payer groups, but you also have the high risk, high need population in all 3 payer groups. And most HIV CBOs have the ability to offer something meaningful to the wide spectrum of payer groups. It's not just Medicaid or Medicare. Though, depending on the context of your organization, you might want to strategically focus on one or really focus in on a strategy around how to approach which payer group first before the others, where you can have a more likely chance of engaging that member because of the demographic and population mix that you're already used to serving. We also have an attachment in our toolkit that is on the website with the Blue Cross and Blue Shield entities and their market share, I believe it is. And that could also give you a sense of the holes that they have in each of your respective states, and give you a sense of a strategy on the value of reaching out to them. Next slide.
Hey,
so
Purnima,
one of the
Oh, I'm sorry, I just wanted to interject that, the enrollment by county, by health plan of the population enrolled in Medicare health plans is public information on the CMS website, and typically the Medicaid health plans enrollment is available on a state website or a national. We certainly have spreadsheets with all of that information in it, but one thing you can identify, in addition to who the BCBS plans are, and if you just do a web search of who the top commercial plans are in any given state, that will come up in a report for you as well. But in terms of determining which health plans have how many lives, that won't tell you how many persons with HIV are in there, but it's a pretty good proxy for how the HIV population is distributed as well. That is very accessible in terms of who you should be excited about approaching, in terms of where the lives are. Sorry.
Thanks, Joel. Great point. No, that's great. So that's step one, right? But there's also another important step that I'm sure every one of you have really thought through, but your SWOT analysis. The strengths, weakness, opportunities, and threats. I'm not going to go through each of these questions, but I think it is important to recognize and understand, where your threat is, if it's the decrease and reduction of funding, or the inability to ensure stable funding, and figuring out those strengths and your differentiators, and aligning to the need in your community, in your state, depending on your geographic presence, and aligning to the gaps in those in that community, or aligning to the gaps in the continuum of care, and then assessing your weaknesses to make sure that you're staying grounded as to, yes, this is stuff we can do. This is how we can better position a MCO. This is a value proposition we're offering, but acknowledging that these are all achievable, especially the first time you engage with an MCO or any payer. It's crucial to set realistic goals and realistic objectives. During one of our 6-part series, we're going to talk about setting an actual contract, and that will go into more detail. But it is crucial to begin to have that thought at the beginning, to make sure that you're grounded to what it is that you can do and cannot commit to, because the arrangements that you have with MCOs are initial arrangements that can lead to better, bigger opportunities. So you want to position yourself in a way that you are taking on a little bit of risk for the MCO, to show that you're being a true partner and you can manage, but you want to show that you can achieve the success, and you want to be a little bit careful there too. Sometimes with the different populations, especially if it's not in alignment with the same population you've served, you do need to consider all those elements so that you're entering into a successful relationship and a long-term relationship. Okay, so the next slide is a slide for questions. So why don't we go ahead and begin the Q&A process.
You all can use the chat box, the little blue circle in the lower left-hand corner of your screen, to chat us a question, and we will respond over the phone. So we'll take a minute or two to let those questions roll in.
Well, while that's going on, I'll just sort of, if it's okay, just lay out what the topics are of the next set of ones that we'll go into in a lot more depth than we have so far today. But on August 14th, we're talking about just how to identify and how to make kind of one common thread. And this webinar series is kind of emanating from a 6-month project we did last year with 4 case study sites of trying to help them connect specifically with the payer community in their parts of the state. But one of the common themes we heard from them is, we don't know where to start. We don't have a connection to them. We don't have a relationship with them, and there's a lot of figuring out who they are and which people to contact and how to get in front of them in what way that we'll go into on August 14th. September 20th, we'll go through what we think some of the best paths are to getting in play. And one spoiler alert or whatever for that one is, we think it makes sense for you guys to get a small, successful contract in place and try to get some kind of big yes contract to happen, right out of the gate. We think you guys are going to be successful improving your value if you get in, but it's going to be hard to get in big with a lot of these entities right out of the gate. So to some degree, we're looking at ways that you can come in on a small scale and earn your way to a bigger contract from within, rather than just negotiate your way to a big contract at the outset. Is an example of September 20th. October 11th, creating a pilot program is similar to that whole thing, but a lot of this falls in the initial meetings and trying to get the data analytics to happen so that you can sit down with the payer pre-contract and figure out with them where their problem points are and how you can help. And that's October 11th. November 15th, I think we're going to bring in a lot of whatever one-on-one coaching we've done, and we're going to bring in some of our specific findings and learnings from the 4 case study sites last year and so forth. But I think that's going to focus on reflecting back to everybody what we've done and learned and hopefully achieved at a micro level with you guys over the upcoming months. And December 6th, we'll try to wrap this all up with what we think as this evolves, we're going to learn some things that are worth, putting into that last bucket, and we'll have a wrap-up session on December 6th. So that's the roadmap going forward.
All right, thank you, Joel. So we have a few questions. The first says, what is your experience getting MCOs to pilot initiatives addressing social determinants of health, recognizing that Medicaid obviously typically only pays for traditional healthcare services?
So I can start there, and Joel, please feel free to jump in. So social determinants of health is like the buzzword that's going around Medicaid contracts these days. I think over the past 2 years, we've seen in the contract requirements that explicitly require Medicaid managed care organizations to address how they're going to, in their response to proposals, but in the contract as well, address the social needs. And they call out food, housing, transportation, and sometimes they also leave it up to the MCO define what social determinant areas need to be really focused on for that state. Again, this is state by state. Some states are already there, and some states are still trying to figure it out themselves and still trying to understand it. But payers are there. It has been the buzzword for a while, and payers also do, within their own care management program, do try to address social determinants when it's a barrier to health. And so they do feel like they have been doing it, and they also understand that in order to address social determinants, it's best for that to have been done locally, face to face. And so I think payers are ready. I think contracts with Medicaid between the states and the Medicaid managed care organizations are explicitly calling it out, and there's a lot of opportunity here for your HIV CBOs to actually take on a great role here, as long as you can get into the community face-to-face, add something that the payers are not able to do, because payers can also get face-to-face, but they might not be the trusted face. So, Joel, do you have anything to add?
Yeah, maybe. Just, to wave the Medicaid managed care flag a little bit, I think the things Purnima was describing particularly reside in the Medicaid managed care arena, and they're finding their way into Medicare and the commercial arenas more slowly but certainly steadily. But, a neat thing about Medicaid in sort of almost a backwards way, but in commercial insurance companies and Medicare Advantage health plans, those are the Medicare HMOs essentially, they have lots of levers to try to make things work. They use co-pays, they use premium modifications to try to save costs and make money, and design their benefits in a way, and they throw extra benefits on the pile that Medicare doesn't cover to get people to join, or all kinds of benefits options, and they use all these co-payment structures to try to keep their costs down. A key thing that they do to keep their costs down is to negotiate prices with the provider community and get discounts as deeply as they can. None of that's really available in Medicaid. And Medicaid, you cannot impose any meaningful cost sharing on an impoverished person. That's just going to put a barrier to care that on top of the ones that are already there, with all the insults of poverty. So that doesn't exist in a meaningful way. There's nominal co-pays for office visits and prescriptions here and there, but for the most part, the care is free in Medicaid and needs to be. People are broke. And so that lever is not available to the payer community to try to control costs. Benefits design isn't really available. Medicaid's got a very generous benefits package. Adding to it isn't that affordable, and adding to it there isn't a marketing aspect. The population in Medicaid is being put into managed care. They can't have pure unmanaged, go wherever you want, fee-for-service anymore. That option is taken away in the Medicaid arena. You have to join one of these three plans, but there is not a benefits addition sort of competition and pretzel palace of different benefits options I don't know how seniors figure out. I mean, there's 25 or so different health plans in almost every county now in Medicare with all their different products, and it's just a dizzying, too much choice and too many options and way too much marketing money, by the way. I mean, the Medicare Advantage program is, the managed care competition is around who can sell people in with the additional benefits and with their marketing spend and their advertising. That doesn't exist in Medicaid. You can't get people in that way. And you can't negotiate prices down in Medicaid. Medicaid's a crummy payer. A lot of you have probably directly experienced that if you provide direct health care services. But it's not viable for the health plans to do some sort of discount for volume. I'll steer 20,000 more patients towards you if you give me 12% off of what we would normally pay one another. That's not available in Medicaid. So what are you left with in Medicaid? Actually coordinating the person's care, getting at the person, and actually coordinating the person's care means being very cognizant of the social determinants and trying however you can to keep them healthy by way of their housing, by way of their lifestyle and nutrition, and how they can deal with the temperature in the cold months of the year and so forth. There's just a lot of supports that can make an incredible difference, and there's lots of linkages to community resources, and there's lots of things the health plans can and do directly pay for because it saves them on the health care spend. So in the Medicaid arena, both because of the procurement and contract requirements, and there's 4 or 5 questions out of the 70 or so in every Medicaid RFP now that determines who the 4 health plans are that are expressly about how you're going to do in social determinants, various aspects of that. They're all in the lion's den. They need to win the bid, and they need to get at the social determinants to succeed anyways. So there is people have all drunken that Kool-Aid in terms of being on board. Medicaid cannot afford to house people and feed people off of the Medicaid health premium. That's ridiculous. But Medicaid can't afford, but Medicaid can't afford. Medicaid health plans can't afford to not do anything about food and nutrition and housing either. And so there's a balance, and there's trying to figure out how they can make the most impact as cost effectively as possible and connect people to better resources. And there's a growing effort to try to help people improve their circumstances through work and through on the revenue side of their lives as well, which is another one that's coming to play more in many states right now. So anyways, that all between the two of us, we may not have answered your question very well, but that's what we got.
Great, thank you all. So we have 2 questions in the queue, so I just wanted to send a reminder to our participants. We have about 20 minutes left on the webinar, so please, if you have questions, use the chat box to send those to us so that we can get those answered during the call. And the next question is, have you developed best clinical practice guidelines?
I can take a shot. We have not. We're not clinicians in our firm, and so we, as in the Menges Group, has not developed clinical guidelines. We have access to a lot of documents of that nature. I will say the fundamental formula for taking from a health plan's point of view and from a care coordination point of view, from out sort of beyond being just a healthcare provider, is a comprehensive assessment at the front end to see what the person's needs are, who the caregiver is, who the village of caregivers might be if it's more than one that are supporting the individual, the high needs individual, assessing what their health needs are and their circumstances, assessing their social determinants, their housing stability, their weight, their whole slew of things to try to get at just how equipped they are to self-manage or to in some way manage whatever health conditions they have, and then obviously catalog everything that's going on clinically with the person. But there's the assessment that occurs at the front end to get your hands around this high need person that you're responsible for financially now and care-wise. The quality and thoroughness of that assessment has mushroomed over the past 10 years. And I think people are realizing that investing, heavily in understanding, even going out and meeting with the person and also creating a personal relationship rather than a telephonic, 20-minute survey sort of thing, there's only kind of one chance to make a good first impression. So health plans are starting to learn to do more and more and more at the front door of enrollment to really get their hands around what's going on in Stu's life and in Stu's family's life and so forth, so that they can be equipped to provide the right kind of support to Stu and see what the gaps are. And then, behind that, an individualized care plan. So this is kind of the best practice of care coordination for a high-need person, by the way. It's not a clinical guideline, but this is sort of a care coordination best practice. So phase 1 is that comprehensive assessment. The second step would be creating an individualized care plan. So getting a team together of the key clinicians who are in Stu's life and the key family members and so forth. There could be, oftentimes that's going to be a behavioral health practitioner and a primary care practitioner and a specialist or two, depending on what the complex combination of things that are Stu's clinical challenges are. It could be a rabbi, whoever's can profoundly help Stu succeed. It can be part of this sort of individualized care plan team, and you develop a plan of what you're going to do over the upcoming 6 months to try to best deliver health to Stu. And that's a written plan. It's shared around with everybody, signed off by everybody, and everybody has their role, including Stu, the patient. And then, circumstances arrive. Stu gets admitted for some reason, or has an emergency visit, or has a car crash or whatever, and circumstances change. Then you revise the care plan, you reconvene, and so forth. But in any event, you implement the care plan, you modify it, and you revisit it at least every 6 months or so to accommodate what can change to now with the new, now that we're in a different period of time, make sure we're still on the best track with our care plan. So getting the initial care plan in place and then modifying it as appropriate. And you can also be modifying who the team is as Stu might move or someone might pass away, and all kinds of things can change in terms of who his team might want to change providers. So that's kind of the core of good care coordination to persons with HIV and other high-need persons like Purnima was mentioning. But we can obtain and probably get get you clinical guidelines of any ilk, you can just email us or connect us, and we can try to, if there's specific clinical guidelines you're interested in, we can provide that. And if there's specific care coordination guidelines, the process I described is in writing all over the place. We can get you that as well if you're interested.
Right, and MCOs typically, and states typically also require that MCOs use standard guidelines. So if you look at ASM and other accrediting bodies that have these, national bodies that have these guidelines published, states and MCOs heavily rely on them most of the time.
And I didn't mention this, but I should have. I mean, understanding what medications Stu is on, and making sure that that's an appropriate mix of things, and then helping him adhere going forward is a crucial component of care for HIV, as well as just about any other chronic condition you name. But prescription drugs are central to everyone's health care who has significant needs at this point.
Great, thank you. So folks, keep those questions coming in. We have one more in the queue. This question says, one of our values is in treating patients through our harm reduction program. We avoid ED visits and inpatient admissions by treating patients when they come to our syringe access program. We are undoubtedly saving payers money. How can we leverage that into a value-based contracting strategy?
So Joel, I want you to answer this question, but this is super exciting, and I just want to quickly say that this is one of the entry points that MCOs see. There are safe station or fire station programs that are, I think, gaining speed here in this space, and MCOs really see this as, or you can convince the MCO that this is an entry point to really understand the member's need and get them connected to the MCO. Oftentimes, for example, as evidence here, you have this great program where the member is seeking care, seeking services, is coming to a certain location, and for the ability to have of an MCO to have a presence, they I think would really see the value of that, and you have to demonstrate the value that you're bringing here. To answer the question being asked, Joel, in terms of value-based, Joel's the guru on this, and so I'm going to leave it to him.
I can't live up to that billing, but a challenge for the payer community with sort of a syringe initiative is, some shade of smallish share of the HIV infected population are going to be enrollees of that health plan. So it's awkward for the health plan to pay for an entire public health benefit. Although I fully agree with the statement that this is saving the payers money, for their enrollees who are accessing the syringes and warding off illness that way and infection. But this type of initiative with a specific health plan might best be part of your tailored partnership of what you're going to do for their members, and maybe even mailing syringes or whatever to certain enrollees who've exhibited certain care, who've had infection issues and so forth, and have clear drug abuse issues. But doing something population wide when the health plan only serves a small portion of the population is a tough thing to ask the health plan to invest heavily in. But getting surgically connected to the health plans, people who have those needs and circumstances, is a great investment for the health plan. So that's part of what you'd want to sit down and try to do in your partnership with them. But you also might be able to create a collaborative of health plans who would collectively invest, in your program.
And Joel mentioned this earlier, but data is so key to managed care organizations so that they can really identify their high-risk members and also just to get their hands around these members and understand their needs. And getting an assessment done when they're there at the program, and sharing that with the payer, with the MCO, that's invaluable to the MCO, and that's a process that could lead again to some form of a collaborative effort and engagement.
All right. We don't have any more questions at this time, so I'm going to pause for a couple moments to go over a couple more things, and we'll see if any additional questions come in. Just a quick reminder that our next webinar will be on August 14th, and it will be on reaching out to payers. I also wanted to mention that this webinar will be available online on Age United's website on our resource page. The slides and the recording will be available in the next few days. I wanted to go over quickly the coaching portion of this webinar series again. So any HCBO that's interested in coaching by the Menges Group should send an email to myself and Paola at st@ageunited.org. Just let us know that you're interested in the coaching. We'll do an eligibility screening to make sure that HCBOs are applying for this, and then we'll put you into contact with the Menges Group, who will follow up to set up introductory meetings. And so we have a couple more minutes on the webinar, so if any last-minute questions are on your mind, please send them, and we'll give just a minute or so to let those come in.
I'll just fill the pause with, on the prescription drug adherence side, there's a lot of fantastic things that health plans can do to help your guys' members, the technology resources they have, the real-time nature, and that they have the data on what, immediately, because the pharmacy claims get paid immediately. But you can do a lot of things. They can ping people if a refill is due in the next 2 or 3 days and hasn't occurred yet, et cetera. But there's also ways you can leverage in your partnership with their technology and data resources that you often won't have access to yourself otherwise, to do a better job for your clients. So there's in working with them, you can do your core work better for your clientele as well in areas like RX adherence. And you can also be kind of better cognizant through your partnership with them of what other health conditions are nipping at a given person.
All right, so we don't have any additional questions, so we will wrap up a little bit early. Again, for inquiries about individual coaching, please give us an email, st@ageunited.org. This webinar, along with the previous webinar on an overview of monetization, will be available at Age United's website on our resources page. And with that, I will say goodbye. Thank you to our presenters. Thank you to those of you who joined us today. I hope everyone has a wonderful afternoon.
Thank you.